Hi, this is the GAPP, MASLD, and MASH Community Network. My name is April Morris. I'm a family nurse practitioner, and I've been in liver disease for many years, as well as endocrinology. And so here is the QR code to record your attendance for this meeting. So make sure you scan the QR code so it can count. And so today we'll talk about non-invasive testing, or NITs. You'll hear me say that quite a bit. And so, to help contextualize this further, let's review a typical patient presentation being referred to for assessment of suspected MASLD. And so here we have Mr. Albert. He's a 65-year-old male with obesity. He's referred for evaluation of elevated liver enzymes with abdominal ultrasound remarkable for increased echogenicity, consistent with steatosis. And so you see his laboratory values. His triglycerides are 89, which are not bad. HDL 41, hemoglobin A1C is 7.2%, in the diabetes range, but relatively controlled. ALT is with known elevation for 3 years, 1 to 2 times upper limit of normal. And so the evaluation of other liver diseases or other causes of liver disease has been unremarkable or negative. It's been ruled out. And so you see his alcohol history here. He hasn't had any significant amounts of alcohol since when he was in his 20s, and he's 65 now. So that's actually ruled out alcoholic liver disease. Medical history, he does have type 2 diabetes, hypertension, and hyperlipidemia. The key physical exam to note is that he does have abdominal adiposity or more of that visceral fat, no stigmata of advanced liver disease, and his BMI is 29. So not quite obese, but pretty much there, like borderline obese. And so given Albert's workup, the most likely diagnosis is MASLD. And so the question remains, does Albert have significant fibrosis? And so the landscape of non-invasive assessment of liver disease in 2025 is quite broad. Generally, it includes biomarkers for liver fat, including things like ultrasound quantitative techniques, MRI, PDFF, shear wave elastography, vibration controlled transient elastography, FIB4, some, calculations, NAFLD fibrosis score, APRI, and then proprietary serum markers for fibrosis, things like ELF, which we'll talk about. And then finally, combined rules that utilize results of imaging biomarkers, serum values, and clinical prediction rules. So for the presentation today, I'll be focused on the specific NITs highlighted in the orange-brown color. And so FIB4 is a simple, accessible NIT that utilizes ALT and AST and platelet count values from routine blood work and in combination with the patient's age. So with that, we draw these labs all the time. It's easy to get this calculation to assess whether a patient has high or low probability of advanced fibrosis. Because of its simplicity and accessibility, it is often the first NIT to be applied to the patients with MASLD. And for example, our Richmond local Veterans Hospital, if you have these components, the platelet count, ALT, and of course the age, it automatically will calculate that FIB4 for you. So that's an easy first non-invasive, test to kind of check for, hey, does this patient, is he at high risk of liver fibrosis or advanced liver disease? And so the enhanced liver fibrosis score, or ELF, it's a proprietary blood test that measures 3 markers of matrix turnover, a marker of active fibrosis, which is a marker for active fibrosis development. Results between 7.77 and 9.8 are consistent with significant fibrosis. And so when you see these, the cut point here, you want to look for those, the sensitivity and specificity and how it sort of overlaps. And that is sort of the cut point with those values. And so a major advance in non-invasive assessment of liver disease is the use of liver stiffness as a biomarker of fibrosis. So stiffness is the ability of an object to resist deformation in response to an applied force. Shear wave travels faster through a stiff liver, and liver stiffness increases with fibrosis stage. So this slide shows the imaging differences between transient elastography, MR elastography or MRE, and point shear wave elastography and 2D shear wave elastography. So when you look at the 2D SWE or shear wave elastography and point or P shear wave elastography, what's the difference? And the main difference is that point, PSWE assessment of stiffness is made at one point and the size of the region is fixed. It is usually smaller, between 1 centimeter, but usually 1 centimeter by 0.5 centimeter, and where 2D actually allows the operator to modify the size of the point of region or the region of interest, I'm sorry, 2 centimeters by 2 centimeters, and to obtain real-time colored stiffness maps. So it's a little bit more specific in when we look at sort of liver fibrosis through imaging. And so I think the most often used imaging biomarker for liver stiffness and steatosis is vibration-controlled transient elastography, or VCTE, or FibroScan. We use the FibroScan as you see on the picture here to the right. It's the handheld, and the one that's most popular is the one on wheels. And it basically is a point of care test. You know the results right away, and that it involves acquisition of pulse echo ultrasound signals to measure liver stiffness. It includes a measurement of steatosis as well through the CAPP score, which measures the attenuation of ultrasound waves as they pass through the liver and compares to normal liver attenuation. So fat in the liver absorbs more of the ultrasound signal, reducing the amount of the returns to the probe. So the CAPP range usually is between 100 and 400, and liver stiffness, steatosis, is defined as a medium CAPP of 236 or higher. And so when you do this, you can actually check for fibrosis as well as the amount of liver and average amount of fat in the liver, steatosis with the CAPP. And so some considerations when we use VCTE for sort of diagnostic purposes or just kind of to help guide us is that you want to ensure that there are 10 valid measurements, ensuring that the IQR median is less than 30%. There's a good image quality, and the operator has experience and has a high success rate in obtaining these measurements. And it is also important to consider the patient, right? You want to look at some confounding factors that could include laboratory factors such as very, very high ALT or ALT and AST, which can be signs of cholestasis, morbid obesity. If they're morbidly obese, sometimes it's very hard to get a true accurate reading. And also the presence of ascites. You want to make sure they don't have ascites because clearly your results are not going to be accurate. All of these factors mentioned can impact image acquisition and diagnostic, accuracy. How can we trust these numbers if you have other factors in play that can really sort of skew the results? So you have to be careful with that. And I think the client should fast. They shouldn't have eaten a good big breakfast or a meal before this test because that also can skew the results. And so MRE, or MR elastography, it's a proprietary software that utilizes shear wave technology. It's an acoustic driver is placed on the patient, and it produces images that are called elastograms that are quantitative multicolor cross-sectional maps of liver stiffness. And so some considerations when ordering MRE is that certain patients are also not eligible for this, especially when they have a BMI over 40, which is hard because, of course, morbid obesity is a risk factor of having MASLD or MASH. But if it's over 40, a lot of times, I know even our radiology department won't do it just because it's not going to be accurate if they have a history of iron overload, non-MRI compatible implants, things like a defibrillator, pacemaker. Those are things that you don't want to put in any kind of MR. claustrophobia, or hepatic congestion. So those are things you just want to make sure to be aware of when you order this test. And of course, insurance issues. Sometimes you just can't get this approved, as we know with insurance companies. And so this is a great, what I call a great snapshot. This slide compares some of the most common NITs that we just discussed and includes recommended cut points to, rule in or out advanced fibrosis, as well as each test limitations and strengths. So it's a great reference to keep front and center when considering, ordering, and interpreting NITs. So it's just a great snapshot in the different NITs we use now. So this is a great one to kind of keep on hand. And so back to our case with Albert. So we have diagnosed him with MASLD. Now we need to figure out, okay, his fibrosis score or his assessing his fibrosis. And if he has, advanced liver disease, can we just watch and wait and talk about other things? So his results are here. And I'm sorry. Huh. I'm sorry. I thought it was the results, but I guess not. Um, so it's this, oh, okay. So as discussed previously, clinical decision tools have been updated to help guide the application of NITs, and we will apply, yes, we will apply these for Albert. And so you see here when you look at the sort of algorithm and what you should do and looking at the risk factors he has, his FIT4 score, which is the first thing you do with the labs that we have here, is 2.22. And that's an intermediate risk of significant fibrosis. So what should we do next? And so the next thing you sort of another non-invasive marker we can do or test we can do is a FibroScan. His FibroScan was 6.7 kilopascals, which puts him at low risk of fibrosis, which is great. And so then you want to discuss with Albert or the client or patient that we need to make sure you modify your lifestyle, making sure you do less sugar, less carbs, making sure your comorbidities are well controlled. And then we follow up, in a couple years to monitor and manage sort of if the fibrosis is progressing or is he actually doing those lifestyle modifications to improve his liver. And so primary care can absolutely follow this patient and make sure all of these, diabetes, hypertension, hyperlipidemia are well controlled. But in 2 years, we want to see, okay, is his liver getting worse, getting better, his enzymes, what are things looking like? And so we can reassess him later on down the road. But this patient is at low risk of fibrosis progression. So he does truly have MASLD and not MASH. And so if you want to visit the GHAPP MASLD MASH Community Network to view MASH disease state education and Resdifra promotional program, definitely use this QR code here to kind of tap into those resources. And so I thank you for your time and I hope you have a great day.